are in listen-only mode.
Good afternoon, and thank you for joining us today as the National Board of Public Health Examiners present our third in our series of 5 webinars geared to explaining the certification in public health credential and to help you prepare for the upcoming exam. Each of our sessions are 2.5 to 3 hours long and include a presentation, a lecture, as well as interactive segments. A break will be offered midway through the presentation today and allows for some questions and answers. This presentation, along with the recorded session, will be archived on the NBPHE website. You may register for the remaining 2 sessions on Behavioral and Health Social Sciences and Biostatistics on the NBPHE website. Today's session is Environmental Health. We are pleased to have Dr. Mark Robson, Professor of Plant Biology and Pathology and Professor of Environmental and Occupational Health, as well as the Dean of Agricultural and Urban Programs at Rutgers University. Dr. Robson?
Well, good afternoon, everyone, and thank you so much for joining the webinar. We'll take a break at 1 and another break at 2. You can go ahead and send your questions online through the system, and Aaron will help me since I'm not the most tech-savvy person, but Aaron and Elliot will help us get the questions, and we'll do our best to answer them as well. So, go into our first slide, which Elliot is not doing.
Could you click into the screen again and then try?
Yeah, I did.
There you go.
There we go. So go into our first slide. What we're going to do this afternoon together is sort of a little introduction to environmental health, and then some of the basic tenets of environmental health that will be reflected on the examination, toxicology, risk assessment, and our 3 major media in environmental health, air, water, and food. And then finally we're going to spend some time to talk about children, since that is one of those important groups of folks that we consider to be a susceptible population. Now remember that the examination is pretty general, and so we're not going to go into enormous depth on any of these, but just help with an overview and sort of a general refresher. Let's start with some definitions. Remember that health is a state of complete physical, mental, and social well-being, not just the absence of disease. And this goes all the way back to 1948 when the WHO defined health. Surprisingly, the WHO didn't define environment till much later in 1995, where they added all which is external to the individual human host, and they talked about biological, social, physical, and any other influence that will that will affect the health status of population. So environment really didn't come in until almost 50 years later, which is kind of an amazing thing. When we talk about environmental health, of course, we look at things at both the local and the global scale. And local could be something like the focus on the environment that really affects the subpopulation that's closest to the exposure, a group of people living next to a Superfund site, a group of folks that live near a toxic waste spill. Though that, of course, is very local. And then we can up it a little bit to the effect on an unbounded environment like the air or the soil or the water supply in an entire region. Think about things like climate change. That's clearly a global public health issue. So we have to constantly keep in balance this notion of local and global environmental health. Now, why do we think environmental health is important? And just as an aside, remember we have 5 areas. But despite the fact that we have 5 areas, clearly the most important of the 5, biostatistics, health education, health administration, epidemiology, and environmental health, clearly the most important of those 5 disciplines is environmental health. And don't you start sending me nasty emails. It's true, and that's all I'm going to say. And here's why it's true. WHO decided that more than a quarter of the global disease burden is caused by environmental exposures that can be averted, things that we can change, things that we can modify. And of course we do this through education, training, and targeted interventions. And that's a very important thing that we have in our toolbox. The WHO says that about 1/3 of the diseases for children under the age of 5 are caused by environmental exposures. Preventing environmental risk can save as many as 4 million lives a year. and those are children in developing countries. So environmental health has the unique character in that we can go ahead and actually do some targeted interventions and really make a difference as people go forward. 13 million deaths annually due to preventable environmental causes. About a third of the death and disease in the least developed regions are due to environmental causes. 40% of the deaths from malaria, and an estimated 94% of the deaths from diarrheal disease, all environmental causes. They can be managed with careful and targeted interventions. So we know that we have an important task in environmental health, just to make this case. The four main diseases influenced by poor environments are diarrhea, lower respiratory infections, unintentional injuries, and malaria. And measures that can be taken now to reduce these environmental disease burdens include very clever things like interventions to have safe drinking water in the home, to purify the drinking water and to store it properly, better hygienic measures, working on ways to better manage waste, household waste, and certainly sewage, safer and cleaner fuels, increased safety of the built environment, which is more of a developed world issue, and finally more judicious use and management of toxic substances, not just in the home but also in the workplace and the environment in general. And so let's look at this WHO map, looking at the population who doesn't have access to safe water. It's a pretty remarkable number, and as you can see, the majority of folks who don't have access to safe water are folks living in the African continent and part of the Asian continent. And it's pretty remarkable in some places, over 60%, as you can see in both West Africa and also Central Africa. So it's a pretty remarkable number of people. Keep that in mind as we go to the next slide, looking at global life expectancy, and see that life expectancy in those same areas is woefully short, in 30 to 40 year range, whereas here in North America we enjoy a life expectancy of about 77 or 78. Our neighbors to the north in Canada even a higher life expectancy. It is a little humbling sometimes when we look at these maps and realize that Japan and Australia and Canada have longer life expectancies, as well as parts of Western Europe, than we do here in the United States, but they do. So continuing to make the case as we dive into our topic today, many countries around the world, those that are developing countries like the countries on the African and South American continent, that's about 80% of the world's population. So 80% of the world's population live in developing countries. And more than 80% of the occupational environmental problems occur in them. So there's a disproportionate burden of environmental disease among folks who are in the developing world. And that's an important thing to remember, that it's a disproportionate burden of folks in this area. Now, that said, those diseases that we see in the developing world are not dissimilar to diseases that some of us saw about 50 years ago here in the United States. So as countries progress and they become more developed and we see their income levels rising, we notice that they in fact will have more and more improvements in the system. But right now they have a disproportionate burden of disease. So let's start with one of the basic things that everyone learns in environmental health, whether he or she is an environmental health major or whether they're just taking the core course because they're in one of the other disciplines, and that's basics of toxicology. And you know, Paracelsus, the famous Swiss physician, said it's the dose that makes the poison. And so I have on the slide for you, just because I think it's kind of interesting, the German version, which sounds a little more interesting than the English version. Paracelsus, by the way, was brought up on charges of being for malpractice, of having killed his patient. And so they brought him up, and he was brought before the judge, and the judge goes, well, I didn't really kill him. I didn't poison him. I just gave him too much. I overtreated him. I had too big a dose. All things are poison. Nothing is without poison. Only the dose permits something not to be poisonous. Or, as many schools, including ours, use the little textbook by Alice Alboni, which is called It's the Dose That Makes the Poison. So Paracelsus, just like your grandmother, when your grandmother said everything in moderation, Paracelsus, hundreds of years before that, said it's the dose that makes the poison. keep that in the back of your mind as we go forward for the rest of our discussion this afternoon. Substances are considered toxic and at one dose and harmless at another dose. And so, even a very ordinary substance can be considered deadly if you consume too much of it. And just as an aside, here's a picture of Paracelsus, just in case you wondered what he looked like. Just for a little humor as we start today, we call Paracelsus the father of toxicology. Now, we also, of course, have the mother of toxicology, Lucrezia Borgia. And Lucrezia was a stunning young woman, the daughter of Pope Alexander, and it is said that she was the first applied toxicologist, that she was able to use her knowledge of poisons to poison her male suitors, not before getting them to sign over their wealth. And so it's said by some that she was the most depraved woman in history, as she kept bottles in her boudoir with perfume that were also there to full of poison to seduce and kill people, and she would use things like arsenic and other kinds of poisons to sort of kill them over time, sort of a chronic poisoning. And there is Lucrezia. As you can see, she was quite the looker. And so the mother and the father of toxicology. Now let's get serious. So applying these terms, some of these terms are useful to know for the examination. There's the term hazard. And hazard, in some people's mind, is considered to be a synonym for toxicity, but hazard is more complex. Hazard includes the conditions of use of the compound. So we say the hazard has two parts. The ability of a chemical or a compound to do harm. It can burst into flames, it can be very toxic, it can explode. That's part of it. But the second part of hazard is how easy you can come into contact with that particular chemical or object of concern. So for instance, if we have a container that's tightly sealed with a really toxic material, but it's in an explosion-proof, unbreakable, tightly sealed container, that compound is not too hazardous. It's still very toxic. You haven't changed the toxicity at all. But what we've done is we have altered the hazard. The second thing that we need to remember as we go forward and get ready for our exam is the notion of time. And so, the dose-time relationship, or being a practical person like I hope to be sometimes, is how much and how often. And the two important terms to remember in this part are those terms for acute toxicity and chronic toxicity. And acute toxicity is a one-shot deal. When you have an exposure that can do systemic damage from a relatively short duration with a one-time exposure. For instance, in the middle of your town, if a tanker truck with some very dangerous industrial chemical turns over in the middle of town on Main Street, those folks that could be exposed to that chemical as it's either being leaked or emitted or vaporized or something in the community, that's the acute toxicity, the one-time, short-term exposure. And then, of course, we have chronic toxicity, a much more complicated issue. But chronic toxicity, of course, refers to harmful systemic effects that happen long-term and usually at very low doses. For instance, if you have something in your drinking water that you're not aware of at a very low dose, obviously it's very toxic right away, you're going to ingest it and get sick really quickly. But if it's a low-level amount, it could over time expose you to something that could lead to some serious health problems, cancer and otherwise. Or you're working in a building, new construction. This has become a big issue for us in environmental health. As we move to entirely man-made manufacturing and construction materials, these materials often have high levels of volatile organic compounds that come off, or other things that can be at risk. So chronic is this low-level, long-term exposure. Acute is usually fairly high-level and one-time exposure. Now, how do we describe typically acute toxicity? And this is a good thing to remember. When you see LD50, lethal dose 50, it is a measurement, it's an index for acute toxicity. And in a few minutes I'm going to talk about the fact that there's some utility in the LD50 number for chronic toxicity also. But generally speaking, we think about LD50s as a measurement or index for acute toxicity. And the subscript 50 is the percentage of the population that is affected based on the administered dose. So LD, lethal dose, subscript 50, 50% of the population that has a lethal effect dies. If we had an LD 0, there'd be no resultant deaths. So we had an LD 90, 90%, and an LD 100, of course, everybody would die. The units, it's a dose. It's important to remember that. This is really critical. It's a dose, so it's milligrams of chemical per kilogram of body weight. So in susceptible populations, remember, we have folks that are less able to sustain some of these exposures. So children who are small, obviously, the US EPA says about 10 kilograms, that's about 22 pounds. That's their definition of a child, versus an adult. The adult, according to EPA, is a 70 kilogram, that's about a 154 pound person. That they are the, quote, typical person. And so obviously a child is much more at risk. It is more susceptible. If you look at the continuum of susceptible populations, it's usually the baby in utero, and then after mom has the baby, the neonate, the new child, especially the first few years of life. And then as we get closer to, sadly, where your instructors is on the continuum in old age, as things start to deteriorate and falter, you become more at risk. So for most of you listening to the call, as young public health professionals, you are all very well able and suited to withstand a toxic assault of some type. So on both ends of the continuum, the baby in utero and the neonate, and on the other end of the continuum, geriatric people who start to have some serious health issues. In the mix, of course, too, are people that are immunocompromised and have sort of special conditions. But on both ends of the spectrum is where that risk lies. And as we look at this, we keep that in mind because it's milligrams of chemical per kilogram of body weight. So a very small person, a child, of course, is going to be at greater risk. The smaller the LD50, the less the amount of material to kill the object, the rodent, the person, the whatever organism we're trying to kill. That way we say LD50 and acute toxicity are inversely related. So if you see you're asked to consult on a manufacturing process, and the person said, look, I have 4 chemicals that I can use. Here are their acute toxicities, and acute toxicity, acute exposure can be an issue. You're going to want to go with a compound that has the highest LD50. That means it's got the lowest toxicity. So if you see something LD50 of 10,000, it's pretty non-toxic. You decide something with LD50 of 1 or 2, it's remarkably toxic, and you have to be mindful of that. So remember that they're inversely related. And here's a little chart to put it in layman's terms. You're at a holiday party, or you're at a function at work, and someone else who doesn't have this wonderful background that you have said, well, how much is that, on average? And you can give them the teaspoon, tablespoon adventure. And as you can see, for something that's got an LD50 of greater than 5,000, for a child, it's as much as 4 tablespoons. For an adult, it's practically a pound. So those compounds with high LD50s, it takes a lot to go ahead and to be lethal. Not that you have to have too much concern about this, but just to bring it up so that you remember this, we also do things based on inhalation, not just dermal and oral. And for inhalation, we do something that we do LC, lethal concentration. And once again, we measure it. Typically, the benchmark is LC50, the lethal concentration that would kill 50% of a population who had the administered dose. And it's usually done by exposing rats or mice or another test animal, typically rats or mice, and they expose to the air, and they'll breathe it for a 1-hour period, and then they watch them carefully for 2 weeks to see what the effects are. So one of the challenges we have in public health, remember Paracelsus, remember grandmother, one of the challenges we have in public health is it really is the dose that makes the poison. Paracelsus was right. He's also in a lot of trouble. He was trying to protect his own hide, but he was absolutely right. Everything in moderation. So here's a good example, vitamin D. Now, how do we get vitamin D mostly? And I'm assuming some of you are going to say a bite outside from the sun, and that's the right answer. The other answer, of course, is to take it orally as a vitamin, as a drug. And then finally, in bread and milk. We fortify milk, we fortify bread. with vitamin D. The vitamin D on its own has an LD50 of 10 milligrams per kilogram. That's pretty darn toxic, about 400,000 international units per kilogram. The pesticide parathion, just as a comparison, has the same LD50 of 10 milligrams per kilogram. Somehow, parathion is very mindful of the fact that it's highly toxic. Vitamin D, not so much. In fact, if vitamin D wasn't already a food additive, it would need to carry a poison label, a toxic label. Everybody in the U.S. needs about 10 micrograms per day. You see the difference in units. The toxic level is 10 milligrams per kilogram. The threshold for health is about 10 micrograms per day. So the same product is really important or really dangerous. Another one, just to give an example, is the highly acutely toxic sodium fluoride. Okay, sodium fluoride, 35 milligrams per kilogram. And yet, we give people chronic low doses of it all the time for good dental health. If you are a person who is on well water, which a large percentage of the population of the United States is on well water, your pediatrician will prescribe for your kids or young people about 1 or 2 milligrams per day for good dental health. And so it's usually administered in a tablet form. It's kind of interesting. Once in a while you'll have someone who'll say, oh, I just let my kids, take those on their own. Well, I decided when my daughter was very young that I would see what it tastes like, and they were watermelon flavored, and I think she obviously had more sense than her father, but I would have had that tendency as a little person to just probably eat a fistful of these really yummy fluoride tablets, but we never let her self-administer. We always did that. If you exceed the dose from 1 or 2 milligrams per day to 3 or 4 milligrams per day, you get serious discoloration, or mottling is the SAT word, but discoloration of your tooth enamel. And so it's really critical. One tablet, which is usually 1 or 2 milligrams, really important for good dental health. We have eliminated, as a public health, an important public health measure, we have eliminated lots and lots of dental problems in young people in particular by the use of fluoridated water. That's a big score positive for public health. At the same time, if we just get the dose a little bit higher, we can cause not certainly a toxic situation, but we can discolor the enamel of the teeth, and then later on you'll see epi-studies where they have high levels of fluoridation where people get fluoridosis. In people on public supply water, the municipality or the city often will fluoridate the water, and sometimes there's a lot of public debate about that, but the American Dental Association, the American Academy of Pediatrics, and other folks have come down very much on the side of fluoride is a good thing in water or administered in tablets for healthy teeth in young people in particular. And as an aside, I was doing a workshop a few years ago at Hunter College, which is in New York City, and it was for environmental health nurses. And one of the nurses came to me during the break and said, I just wanted to give you a little anecdote about the fluoride. They had lived in rural New York, and she took a position in a suburb of New York City where they have city water and it's fluoridated. And she continued, she just wasn't aware of the fact it was fluoridated, she continued to administer to her children the fluoride tablets. And eventually her son had pretty severely discolored enamel on his teeth. She showed me a picture of a very handsome young man, and he was going to go to school in New York City to be a theater arts major. And so she ended up having to cap his front teeth because of the discoloration. So she said, well, it wasn't a public health issue. The dose thing really did make a difference, and in this case, it was an occupational concern because, of course, you need to have very good looks to work in the entertainment industry. And so just that little mess up of having fluoridated water and continuing the 1 tablet per day ended up having some bad effects for that family. So we talked about acute and we talked about chronic. We talked about dose in terms of milligrams per kilogram. Now let's talk about how this all fits together. It fits together through exposure. Routes of exposure, there are lots of routes of exposure. The three that we're going to spend time on for the next couple minutes are penetration through the skin, dermal exposure, absorption through the lungs, inhalation exposure, and finally passage across the walls of the GI tract, and that's oral. So dermal, inhalation, and oral are the three major routes. Obviously, there are many other routes as well. You can have intraperitoneal. You can, when you get shot, when you go to the doctor's office, you get intramuscular. There's lots of ways to have exposure, but the three big ones, which are going to be our focus today, are dermal, inhalation, and oral. And so here's our little schematic. We have the agent on the outside, and we have an exposure dose. It makes its way into our system, either through the skin, the lungs, or the GI tract. And then we have the internal dose. And we worry about that because of absorption. And then it begins to circulate in the body. So distribution and metabolism, usually via the bloodstream, sometimes the lymphatic system. And then finally it hits the target dose. And that is when it affects various organs and tissues of the body. So, you know, when we talk about basic toxicology, when we teach the tox course, we talk about ADME, absorption, distribution, metabolism, and excretion. So on the front end, we're just through exposure, we're going to talk about absorption, distribution, and metabolism. So outside, inside, and then distributed to the organ or system of interest. Dermal is pretty straightforward. Dermal is the most common way that we come in contact with chemicals. That doesn't surprise you. If we were to go ahead and stretch out our skin, the average person has close to about 20 square feet of skin. And the second most common, of course, is inhalation. If you stretch out the lung surface, there's about 750 square feet of lung surface. And so here's a little schematic of skin. Skin is a really effective barrier to chemicals, and thank goodness for that, because that's what's on our outside. The lung is a very poor barrier to chemicals, and that's okay too, because that's what permits us to exchange oxygen when we breathe. If we didn't have the ability to exchange oxygen when we breathe, of course we wouldn't be able to, you know, move the oxygen into the system. But the skin is a pretty good barrier, and that saves us every day. It's a very good adaptive, evolutionary adaptation that man has had over time. Certain parts of the body absorb more rapidly than others, and you know that. Areas where you perspire, of course, will also absorb more rapidly. So under your arms, around your neck, in your groin area, behind the back of your knees, places like that where you would perspire more, you have more rapid absorbance. Inhalation is complicated. Remember, the function of our lung is to deliver oxygen to the blood and to eliminate the CO2. And when you get deep down inside, it's about 1 cell thick where that movement goes back and forth. So that's important evolutionarily. I mean, that's how you can get that one little cell for the oxygen to move across and the CO2 to move back. It's also why you smoke marijuana instead of eat it, just a little practical tip. We also worry that in this alveolar space where all this takes place, that we can get systemic kinds of problems associated with fine particles. Excuse me, not fine particles that will in fact get into the lung and cause some serious health problems. We call these pneumoconioses, and we worry about things like asbestos and silica. Asbestos, of course, is a mine material that we used to use a lot in the United States in construction as an insulator. And later on, we'll talk about the fact that that we have challenges associated with it for asbestosis and mesothelioma and other things. For the silica, which is used in the manufacture of glass and tile and things like that, the same thing, we get silicosis. Again, these dusts get into the deep lung and cause some very serious kinds of problems. And there are other examples too: cotton dust with the conditions called bisonosis, coal dust, which we typically think about as black lung in miners. Sugarcane pulp, which is a very fine dust in countries that still process sugarcane, it's brown lung. So it's a very serious problem. You can see on the schematic what happens is that as these things start to make their way into the system, of course we trap them in a couple places. You know, everything from the heavy particles are trapped up in your nose when you sneeze or cough. A little further down, we can also trap them along the esophageal, and we can go ahead and you'll see people clearing their throat constantly. And finally, they'll make their way down into the deep lung, and then it's very hard to go ahead and clear them. The oral route is mainly through ingestion, and it's typically exposures to the chemicals or through the food that we eat. And chemicals can actually enter the body and are absorbed throughout the entire system, from the mouth all the way to the back end of the system. Absorption can occur anywhere along the system. The majority of it actually takes place in the small intestine. But in some cases, we look at the rectum. If you have children, or if you are a nurse or a doctor that treats kids, you know that sometimes we will administer drugs as a suppository because we can get absorbent back at the back end of the pipe. But normally speaking, of course, the oral through the intake in the mouth, some things react in the oral cavity, like nitroglycerin. If you know people that take nitroglycerin for heart disease, they put it under their tongue, the absorbance will take place. But the business end of this all happens in the small intestine. Ethyl alcohol is absorbed very rapidly in the stomach as well as the intestine, which is why you see the effects of someone who's drinking. The effects happen so quickly, particularly if they're on an empty stomach. Now, once in a while you're here, and most of us work in university settings, or we recently left the university to go out into the world of work, that you'll hear undergraduates particularly say, well, I'm going to eat a big meal so I won't get drunk. No, you'll definitely get drunk. You'll just delay the effects even more by having a stomach full of food. But in time, of course, you will still have the same blood alcohol level. You will still blow the same breathalyzer blood alcohol level when the policeman pulls you over. It'll just delay the effects. The other thing that you have to realize, too, is that after that people will say, well, I've been drinking all night. I better drink some coffee to sober up. No, you'll be a very wide-awake drunk. You will not be at least a bit more sober. You will just only be more wide awake because of the caffeine effect. So how do we go forward and do all this? How do we make this all make sense and try very hard to try and see what is going to affect us as humans, what is going to affect other sentinels in the environment? Well, we usually use animal models, and here you can see someone that's about to participate in an experiment, not necessarily of his own volition. It's important to have these sentinels. It's unethical, of course, to test in humans, and those of you that are already in the field or have done your research for your master's or doctoral work know that we have to have institutional review approval, IRB, and protection of human subjects before we do any study, even the most straightforward study that might even be a questionnaire. This is a very important part of public health. And in environmental health, of course, we worry about trying to determine the toxicity of a particular compound, and with that, we look for animal models. Now, the challenge is, what's the best model? And, we go ahead and we try to find animal models that we think will react the same way we will. And man and monkey are fairly similar most of the time. Monkeys do respond to methanol the same as people. They do not respond to nitrobenzene the same as people. So you have to say, well, what's a better substitute? We're going to talk about that in a little bit more detail now. Animal data and the use of animal data as test sentinels goes back to the days when we had the 1958 Food Amendment, that was Food Additives Amendment, that was part of the FDA, Food and Drug Administration regulations. And that amendment is fairly famous. It's called the Delaney Amendment, because Congressman Delaney had proposed this and had been very adamant about its passage. He didn't want to see anything that could cause cancer in any animal at any level allowed in the food supply. Now, when Congressman Delaney had proposed this, which was a very good thing, I'm a very big fan of Congressman Delaney's and the courage that Congressman Delaney showed in proposing this at a time when it really wasn't a particular interest to the public, we measured things in parts per hundred. And now, you know, we measure things in parts per billion as the norm. Often we get results back from laboratory work that's in parts per trillion, and even in some cases on experimental models even smaller. But at the time that Delaney proposed this, we measured things in parts per hundred. You almost could see it and measure it visually, not quite, but you get my point. The idea was that we could measure it very easily and we had a finite number. Now in 2015 we have this concept called the vanishing zero. And the vanishing zero suggests that no matter what you measure, you're going to find it at some particular level. Our ability to go ahead and to analyze, to calculate, to do the assessment is really quite remarkable in this part per trillion range and lower. Our ability to understand what that number means, you know, 1 part per quadrillion, we measured it. The analytical chemist will tell you very proudly, oh, we found something. But then you and I as health scientists have to say, well, what did we find? Is it important enough to have an adverse outcome, to have an adverse impact on the organism, in this case, people? And that's a big challenge for us to try to determine that. But it's important because we have animal models, and we try to find the right animal model to go ahead and represent you and I. It is our surrogate. In these models, we have things that come into play like age. Age has an influence on toxicity in many toxicity models. DDT, as an example, is not acutely toxic to neonate rats. However, as the rat becomes older, the DDT becomes more and more toxic. So the adult LD50 is about 200 to 300 milligrams per kilogram. The flip side, as we get organophosphate insecticide, parathion is more acutely toxic to newborn rats than adult rats. So DDT, the neonate, gets a pass. For the young rat, when it comes to ethyl parathion, then of course, or ethyl parathion, it's far more toxic to the neonate. So age has a difference, and it has something to do, obviously, with the way that the animal metabolizes these foreign chemicals. Sex also has an influence. There's obvious physical and physiological differences. As an aside, male rats are 10 times more sensitive to liver damage than our female rats when they are exposed at a chronic level, oral chronic level of DDT. And so we're pretty sure that this is hormone mediated and that it's an androgen mediated function. If you go ahead and castrate the rat, remove the testes, of course you're going to decrease the testosterone, the androgen source, and then the rat will have the same level of toxicity as it would if it were a female rat. So you can castrate the rat and get a lot less liver damage. It will also make the rat rather angry, but you do decrease his chance of liver damage. Okay, so, and we've finished our first 40 minutes, and let's spend a little time now on dose response. And so here is a classic dose response curve. You've all had to draw those when you took your public health training, so let's refresh. The x-axis, so one across the bottom, is dose, typically expressed in milligrams per kilogram, because remember that's how we express dose. And the y-axis, the one that goes from top to bottom, is the response. In an LD50 curve, the response is going to be mortality or death. But it's a dose-response curve, so I could very easily change the mortality to improvement if we were measuring TD50. So suppose I work for a pharmaceutical company, and I'm trying to develop some new antibiotics or a new treatment for something, a pharmaceutical treatment. I'm obviously worried about the LD50. I don't want to kill anyone. But I'm more concerned, of course, about how well my drug does. And so I'm going to do therapeutic dose. And so we do a TD, therapeutic dose. And so that y-axis could easily be percent cured or percent affected or something to that effect. So the bottom line in this example is an LD50 curve. The bottom is the dose on the X and the percent is on the top. And so I'll give you a second to look at this, and then we're going to ask what is the LD50 for whatever chemical this mythical chemical is. Oops. Okay, so you had a chance to look at it, and you can tell the LD50 for whatever this chemical is about 220. Okay, you can see that? So if you connect the points and you follow it, of course it's a beautiful straight line, which we never get in science, but it's good enough for today for our example. The LD50, if you draw the line, is about 220. Okay, good. Now let's look at another concept. Let's look at this dose response, and this time we have no units. You see the LD0 and the LD50. I want you to look at this one for a second. Okay. Now let's look at that one. Right? So we have this one and this one. I always tease us like going to the ophthalmologist when they go back and forth. What's better, this one or this one? You go, stop, I'll buy both pairs. Looking at, I always get some snarky email from somebody who is an ophthalmologist saying that's not fair to pick on us like that. We're not picking without you. So here we are. We're looking at this and we see this curve and this curve. And what we notice from these two curves for chemical A and chemical B is the slope of the dose response curve. This is really important. So when we look at the first one, chemical A, we see that the slope is very steep. And from the situation where we have no resultant deaths, our LD0, to where we have LD100 is a pretty short distance across the x-axis. And so we want to keep that in mind because when we look at chemical B, we have our LD0, and we go way out, we have our LD100. And so there's a very long distance between no one dying and complete mortality. Now, why is this important? It's important because suppose we're working in a manufacturing plant, or we're asked to help develop a new process to manufacture something, and you have several choices of chemicals that all work the same in this industrial process. You have to say to yourself, all right, so they might even have the same LD50, by the way. But we want to look at more than just the LD50. We want to take a minute and we want to look at the slope of the dose response curve. Because in the chemical that's on the screen now, chemical B, we have a very wide range of doses from where we have very small mortality, and it takes a long time and a wide range of doses to where we have 100% mortality. And this is really important. Given everything else to be the same, we do okay if we pick the compound that has a much less steep dose response curve, because we can screw up, we can have a misapplication, we can have some minor problems and still protect folks by having this wider range of doses. Remember, in public health, our goal is always to protect people. But remember, in public health, we know that people are going to make mistakes. My mentor, the former dean of the School of Public Health at Pittsburgh, Dr. Bernard Goldstein, one of the smartest people I've ever met. And Dr. Goldstein used to tell first-year public health students, what the basic rules of public health are. What's the first rule? And people look very, very inquisitive, and everybody wants to sound intelligent in front of the department chair, leader, the dean, and they come up with all these clever little things. And Dr. Goldstein would look them straight in the eye and go, no, people screw up. And that's absolutely right. People will make mistakes. And so your goal, and my goal, in this whole process is to reduce the number of mistakes, just like we did here. Chronic toxicity is a process to get our arms around. Chronic toxicity is much more complicated, and there are lots of fancy models and graphs. We don't need to know all of that for our certified public health exam. And so we're now just going to mention what we do need to know. So chronic toxicity was first recognized in occupational illnesses. In fact, if you go back thousands of years, the early physicians in Greece and in Rome noted that certain trades had poorer health than others, and those trades were things like in mining, in metallurgy, in pottery, and people recognized this was a problem. Well, that problem was a function of their chronic exposure to certain chemicals, in this case metals. Hippocrates described severe colic. What he really was describing without knowing it was lead poisoning. Remember, lead is a potent neurotoxin. Pliny the Elder wrote of mercury poisoning in miners from quicksilver mines in Spain. Once again, it was a neurotoxin, and he certainly didn't know the cause was mercury. What he did know is that he saw this very serious neurological impairment, and he wrote about it. Bernardino Ramazzini, of course, the father of occupational medicine, also made these kinds of observations. So these early physicians were really the first people to help us understand this whole notion of chronic toxicity. And you remember when you were little and you read Alice in Wonderland and you read about the Mad Hatter. And as you know, there's a lot of hidden and not so hidden messages in the Alice in Wonderland story. And the whole idea is that the Hatter was mad, meaning he had serious mental illness, was because they used to block hats, these beaver hats, and they would put mercury on the beaver pelt to make it stiff and to make it, have the sheen and the attraction that people wanted it to have for these attractive hats. Of course, that meant repeated exposure to mercury, which in time, of course, led them to all go mad, according to the story. So here is a standard dose-response curve for chronic toxicity. And again, there are lots of complicated models. We're not trying to make this afternoon's time together complicated. We're just trying to refresh you and to remind you of a pretty basic concept where, once again, along the x-axis we have our response, along the y-axis we have the x-axis we have the dose, rather, and on the y-axis we have the response. In this particular time, you can see that the early low amount, the dose, is small. And as you go across, it takes a while before you even see an effect where you have a threshold. And then as you hit that threshold, about 3 inches in on the slide, you'll see that we have an increase in dose. We get an increase in effect. So the effect goes up as the dose goes up. And as we go along, we'll hit a maximum. We'll hit a plateau. And when we hit that plateau, you get to the maximum effect. And then you'll see it'll just continue in that direction. You can't get beyond a certain level. In fact, in some cases, depending on the chemical, you'll see the threshold, it'll go up, and then the maximum, and then it'll actually go back down after you go past whatever that magic dose is for a maximum effect. So not as well represented here, but certainly just to give you the reminder about what a chronic dose response curve looks like. It's one of many, and there are lots of more details that we aren't going to go into today. As we get ready for our first break, we're going to, when we come back, so it's 12:50 now, we'll come back at 1 o'clock. Why don't we pick up with some of the compounds that have had a major impact in U.S. history as far as toxics. So we're going to go, it's 12:50 now, we'll come back at 1, okay? And you can forward your emails, or I guess through the system you can forward your questions, and Aaron will screen them, and hopefully we'll be able to try to start the session answering a few. Okay, see you in 10 minutes.
Thank you, Dr. Upson.
Okay, so we're back. Oops, we're back, and let's get back to work. So let's give some examples of some chemicals that made their way into the marketplace in the U.S. and in other places that are sort of classic environmental hazards that have caused long-term and short-term problems. And the first one is thalidomide. Thalidomide was not marketed in the United States thanks to the very careful vigilance of a woman in the Food and Drug Administration who took to heart the fact that she didn't think the testing was adequate and enough information had been gathered on this drug, and was very strong in resisting it making its way into the U.S. market, and we can always be grateful to her for that. It was marketed outside the United States back in the late 50s, and it was a sedative, and the idea was it was going to combat morning sickness, nausea in pregnant women. It's also used as a sleeping pill, and it was withdrawn from the market in 1961 after it was discovered to be a teratogen. The problem was that not all animal species tested produced the reactions that thalidomide caused that we saw in humans. This is the chemistry of thalidomide. No, you're not going to have to draw structures on the National Public Health Exam, but sometimes people like the chemistry, and so I put it up there for folks that like it. You see it's a pretty complicated structure. And here's an advertisement from thalidomide, and it said, you know, now a new advertisement, because thalidomide is still on the market. When a pregnant woman takes thalidomide 34 to 50 days after the beginning of her last menstrual period, there is a risk of approximately 20% or greater that the baby will have phocomelia. Phocomelia is this extremely short or missing arms and legs and missing ears, and they usually are profoundly deaf. And what's so incredible about this compound is that it's that narrow little window. If mom takes this drug, say 23 days or 27 days after, she's not going to have the problem, or baby's not going to have the problem. And if mom took this drug, you know, say 55 days out, which is unlikely because we're trying to combat morning sickness, by that point morning sickness has subsided. But it's that narrow window of about 16 days where the teratogenic potential of this compound, thalidomide, is so extreme. And the results are remarkably extreme in phocomelia. And you can see what phocomelia does. These are pictures that go back a few years from papers published in the early 80s, but it's just absolutely horrific malformation of these beautiful little children. Some people survive. Most of them don't live a very long time, but there are adults who have phocomelia who have even been quite successful in different things. There's a famous conductor in Europe that has phocomelia and conducts one of the major symphony orchestras. But the point is that the majority of the children don't have, there's no quality of life, and they don't have a very long lifespan. It's a really horrible malformation for these children. And this was something that we learned with thalidomide, and the actual complete understanding of how thalidomide works is still a little hard to follow. There's a wonderful book out if you have time to read it. You don't have time now because you're preparing for your exam, but when you have time later, it's called Dark Remedy, and it's the story of thalidomide. I have a wonderful little list I give my graduate students and my seniors called Dr. Robson's Airplane Books. Of course, I made that up years before there were Nooks and iPads and you know, all these readers, but I still like to have a book in my hand when I fly. And I bought last week, flying home from Thailand, a book called The Last Siamese, the profile of 11 people who were politically active from 1932 until the president in Thailand. So I always like to have one in my hands. But if you want a good airplane book, The Dark Remedy is a really interesting book. It's the story of thalidomide. And what's amazing is thalidomide is still used today. Okay? It's used to treat leprosy, Hansen's disease, and it's approved. Obviously, we don't give it to women who are of childbearing age for the obvious reasons that you just saw with the phocomelia. It's also connected with some treatments for HIV/AIDS. But thalidomide was a classic teratogen, thankfully not marketed in the United States. One that was marketed in the United States, another bad actor, if you will, is diethylstilbestrol, or DES. DES was prescribed to prevent miscarriages And it was prescribed in about a 30-year window from the 1940s through 1970, and it was given in high-risk cases of high-risk pregnancy. And after time, the female offspring of the moms who were administered diethylstilbestrol had higher rates of vaginal adenocarcinomas and some other reproductive problems. And at first we thought it was only affecting the female offspring. And in a minute you'll see that that's not the case. But after the girls who were born from the women who took the diethylstilbestrol started to have these problems, people were able to link it to the fetal exposure of DES in the early part of the pregnancy. And it affects most women at about 16 to 20, the women who are the offspring of the moms who took it. And it happened, we figure in the United States, maybe 1 in every 1,000 pregnancies were exposed in that 30-year window. The chemistry of diethylstilbestrol, in case it's one that interests you, a little less complicated than the thalidomide chemistry. But here's the kicker. We thought this was a good thing. We marketed this. This is an advertisement from a medical journal in 1957. Okay, and then because it's a little hard to follow from the Google image, I went ahead and typed it out for you on the left side of the slide. Recommended for routine prophylaxis in all pregnancies. 96% live delivery using Desplex, which was the theme of this particular formulation of diethylstilbestrol. So this is a classic one. And you know, when you think about the exposure, remember I told you in utero, big risk, very susceptible. What did we see in female children that were born from the moms that took it? We saw vaginal and cervical carcinomas, lots of uterine abnormalities, and much higher rates of preterm labor and miscarriage and ectopic pregnancies. It was a lot tougher for them to have their children. And for the longest time, the focus was almost exclusively on the female offspring. Later on, people started to realize when they went back and looked more carefully that diethylstilbestrol also had an effect on the male offspring from the women who took diethylstilbestrol, abnormal genitalia in the boys, epididymal cysts, undescended testes, and other things. So it was a real challenge to both genders. How do we decide what the challenge is? How do we decide what the risk is? Well, we have this science called risk assessment. Risk assessment, unlike medicine, which is thousands of years old, toxicology, which is hundreds of years old, risk assessment is probably 50 years old. People make risk determinations all the time, so you may say, well, risk assessment is as old as any other science. But we've tried to put some boundaries around it. We've tried to put some science into it. We've tried to make it more focused in recent years, in the last half century. Of course, some people, you know, there was a wonderful joke, and I actually put it in the risk assessment textbook that I edited, which is, why did God invent astrology? And the answer was, it was to give risk assessors more credibility. Or I guess this week we could say, here I live in New Jersey, so I'm talking to you from New Jersey. The storm that wasn't, you know, the meteorologist had proclaimed it was going to be the end of the world. We're going to have 2 feet of snow, and we had 4 inches. As the meteorologist said on my news channel, I overpredicted. So risk assessment, we try not to overpredict. We not try to underpredict, but we try to make an assessment of what that environmental risk might be. But like the weatherman, we have some problems. You know, if you have 3 weathermen in a room, you have 4 opinions about the forecast. And this little cartoon, where the one fellow says to the other, hey, I thought we were working on the same data set. Risk assessment numbers. You and I can use the same data set. We can work very hard. We can follow prescribed protocols and still come up with very different numbers about the risk. So let's look at what some of those are. We're going to introduce the topic with a couple of examples. And I want you to think of this as we start to go through the risk assessment process. This is a classic paper that Crouch and Wilson back in 1982, where they talked about risk communication and how we represent the data. This was done in the 80s now. Remember, now we have extraordinary software where we can do magnificent manipulation of data and with just tweaking a little bit the inputs, we can generate hundreds of beautiful PowerPoint presentations and charts for our papers and our thesis. But if the data is not any good, we still just have a lot of beautiful but probably not very meaningful charts and tables. So this is accidental deaths per million tons of coal mined in the United States between 1950 and 1970. This is real data, and Crouch and Wilson just manipulated the way that they presented it. So x-axis is the year, y-axis is deaths per million tons of coal. And if you looked at this data, you'd say, well, the trend is very positive. The trend shows that accidental deaths in mining, which, as you may remember, is the most dangerous occupation, okay, the accidental deaths are going down, and we're making great progress. Take the same data and just manipulate how you express it. And here we have, okay, accidental deaths per 1,000 coal mine employees during the same time period. It's the same data. It comes from the website from the Department of Labor. And so now x-axis are still years, and the y-axis this time is accidental deaths per 1,000 employees. And you can see enormous variation. So if I asked you what the trend was this time, hopefully you'd say, we don't know, because I don't know, or I didn't know at the time. I mean, we'd have to carry out the paper. It's an old paper, and I don't think anybody's looked at it, taking it out to 2015. But right now you can see it's got peaks and valleys, and the peaks and valleys represent when we had coal mining accidents. It's kind of like air travel. You know, when you look at the risk associated with air travel, you'll see, in general, air travel is pretty safe compared to other modes of transportation. But once in a while you'll see a great big blip, and that great big blip is when we have a terrible accident, as we've had several in this past year. So risk assessment, always a good equation to know for an exam of any type. Risk is equal to hazard times exposure. This is a very generic, very basic, pretty uneventful risk assessment equation. And we determine risk based on looking at a four-step process. This four-step process was approved decades ago by the National Academy of Science, National Research Council, and is employed by federal agencies at EPA, NIH, CDC, FDA, and NRC. So this is the sort of the standard four steps. Hazard identification, which is pretty self-explanatory. What are we looking at? What do we think the risk is? The second step, a little less obvious, the toxicity assessment, which is, in fact, the dose response that we talked about before. Exposure assessment, what rates of exposure, what's the level of exposure, who got exposed to what. If the hazard ID is great, if the toxicity says this is a dangerous stuff but nobody's exposed, we don't have a problem. And we use those first three to come up with the fourth, the characterization of the risk itself. After you identify the hazard, do the dose response, look at who's exposed, you can categorize the risk. Now, those are the four steps we see in every risk textbook. But we're public health people, you and me. So we do two more steps. We try to manage the risk, and we try to communicate what the risk is. Management of the risk is often the domain of the healthcare professional, the nurse, the doctor, the PA. They're the folks that are trying to manage the risk. When you come to the doctor and you say to him or her, you know, I have silicosis. Well, we've already done steps 1 through 4. The identification, the risk is a hazard is silica. And we have enough of an exposure based on our dose that we know we have silicosis. Now we ask the doctor for him or her to manage it through either, you know, lung therapy or some type of surgery, or there's usually never many good outcomes for things like silicosis or asbestosis or things like that. And of course the other step is to communicate what the risk is and try very hard to prevent increasing that problem in other populations. Of course, like this little cartoon where it said, you know, what made him sick? And the doctor says negligible levels of carcinogens. And while this is a, you know, a little satirical cartoon, it's true. We usually don't know what makes us sick. And we use terms like carcinogen and negligible and things like that at, almost in a flip way sometimes in public health, and we find ourselves trying later to explain what in fact we meant. Some of the folks in the public health community are very effective in displaying a way to quantify and qualify the risk. And this is one that came out from the NRDC a few years ago, and they were looking at the pesticides that are applied. In this case, these are insecticides that were applied to, one of them is a fungicide Captan, but the other 7 are insecticides that are applied to apples. And all of them are fairly dangerous and have associated with them some really serious health risks. And so, of course, the amount of apple consumed is the indicator to say how much of this you, in fact, will come in contact with. And so this was a real effective campaign, and it ran in all the national newspapers around the United States, something to chew on. They listed the chemical by the trade name, and they also listed what the health effect was: carcinogen, endocrine disruptor, neurotoxin, and so on. When we do a risk assessment, we have to understand a couple of the boundaries associated with it. It's very easy to say, oh, the risk is enormous. A couple of years ago, well, actually quite a few years ago now, in the 80s, we had the compound Alar. Alar was a compound, diminizide was the chemical name. That's one of the great challenges in environmental health, whether it's a pesticide or an industrial chemical. We typically have a trade name and a common name, and we see that in pharmaceuticals too. A good example would be Tylenol is the trade name, product of Johnson & Johnson. The common name that you might buy it as, if you bought it as a generic, or just if you went in and asked for it, of course, it would have the acetaminophen. So we have a common name and a trade name. At least Tylenol sounds like something you'd probably take as a drug. In the pesticide world, often the trade names are names that are more catchy to the end user, the farmers or the pest control operators, like torpedo or dragnet, different compounds that were used to control termites. Or, there's an herbicide on the market recently I saw, Stomp, and a very long chemical name, but the trade name was Stomp, now S-T-O-M-P. So now I'm the emergency room doctor, and the farmer is admitted to the hospital for whatever reason he or she is spraying, and the spray hose breaks or they get ill, and they said, what were you exposed to? And the doctor's desperately trying to figure out what the chemical exposure was, and the farmer tells them the name that he knows, which is Stomp. And while that might sound a little silly, years ago the compound torpedo was a compound used for termite control. And one Friday afternoon, like magic, you'll find as you advance in your public health career that the problems always happen on Friday afternoons. A young physician from an emergency room in Princeton, New Jersey, about 20 minutes from here, called and said, I don't know what this compound is, I can't find it. The farmers, the pest control operator said that, that they were torpedoed, and because I knew what it was, we talked about what the doctor might do to solve the problem. So it's a great challenge for us to understand what the compounds are. The second part of this story, which is what we have the slide up for, is how much do you consume and who is at risk? Remember the little continuum: pregnant, baby in utero, newborn, healthy adult, as most of you, and then geriatric person. So here's the story of Alar. Alar was on the market. It was used for apples to make them look more red and to keep them on the tree a little bit longer and to keep them crispier in storage. There was no real noticeable beneficial effect from Alar. And the compound was manufactured by Uniroyal, and Uniroyal, in a negotiated agreement, just discontinued manufacture. They didn't cancel the registration because they didn't want to have to indemnify the product, but it went off the market. The people who were against the use of Alar through laboratory tests saw that the metabolite, unsymmetrical dimethylhydrazine, had caused health problems. There was a risk associated with unsymmetrical dimethylhydrazine, and wanted it off the market. The apple farming community, American apple growers, and then New York apple growers, and all the large commodity groups said, "Oh no, we need this stuff. This is good stuff. We need to have it." and eventually went off the market after a 60 minutes expose about the risks associated with Alar. And the cover of Time magazine had Sleeping Beauty with the witch handing her the apple. Remember the Sleeping Beauty story when you were young. It really became a disaster, but it was a risk assessment educational moment. And it was a teachable moment in risk assessment because both sides botched up the dose, and both sides botched up the characterization of the risk. How do you consume apples? Well, that's one of the important things you have to look at. So here's 3 big foods that we consume. And apples, most of us consume it fresh. About 33% of apples are consumed processed. Grapes, about 29% fresh and about 71% processed. And finally, potatoes, about 99% fresh and about 1% processed. So first you have to look at how it's consumed in general. But now, here's the important part. When they did the risk assessment, so they said, okay, the greatest risk for apple juice, the greatest risk in apple consumption is apple juice. And apple juice has the highest level of unsymmetrical dimethylhydrazine. This unsymmetrical dimethylhydrazine is formed during processing and heat. When you make apple juice, especially pasteurized apple juice, that's when it is in the product. And they did the risk assessment on adults. They did the risk assessment on how much apple juice you or I drink. And we're not the risky population. We're not the susceptible, vulnerable population. The susceptible, vulnerable population are the kids. And so look at the picture here. So the average person, whoever he or she is, about 0.4 grams per kilogram per day of apple, okay, and apple juice 0.22, pretty insignificant. Okay, now let's go over to the high-risk crowd. Infants, 2.8 of fresh apples, applesauce and things like that, and 3.4 apple juice. I like to tease and say, as a parent, you know, when I first used to lecture about this topic, that typically children are either on breast milk or formula. From there they go to apple juice, and from there they go to Diet Coke. And it's this important window between breast milk or formula and whatever their young adult beverage is that we worry about when they're drinking apple juice. And look at the difference between the average person, 0.2, and the infant, 3.4. And remember all those other things we talked about as far as, you know, susceptible populations. So the risk assessment was done on the wrong target group. And once it was done on the right target group, and even if you look at kids 2 to 6, it's still 4-fold over, almost 5-fold over what it is for the average person. So you do a risk assessment on me, that's not who's important. The important person is the young person, and it is the neonate, the infant. And when they did that, they recognized that the risk assessment showed that this Alar was a bad actor and had to be removed from the market. Just go into the store and you'll see Alar, you'll see apple juice rather, excuse me. And you know, the first pass was it was pulled in American markets, so that American apple farmers were no longer using Alar. And then I went into the store and was looking around and taking pictures. By the way, it's never a good idea to try to take pictures in a grocery store because they'll escort you out. Despite my pleas that I was a department chair in public health and a dean, they could care less as they helped me out of the store. But on this palette, these pictures of apple juice here, these apple juices are from South America, from Poland, from Hungary, from Argentina, and Uruguay. There weren't any apple juice containers that particular day that were manufactured in the United States. So then the question becomes, okay, we banned it in the U.S. Is it still banned in these other countries? The answer is, at the time, I didn't know. So fresh apple consumption, too, is important. This compound worked as a systemic compound. Even after we discontinued the use of Alar in the apple market, we could still have detectable residues in apple product because of the systemic nature of the product, and there was some residual that remained in the tree. So it became a really big deal. Interestingly, on the last part of the Alar story is the New York Times reporter called up to ask about Alar, and I explained to the person, a very well-informed reporter, very smart, and I explained to her how Alar was used and what we did with it. And you know that most apples at the time in New Jersey, best we could tell, probably 85% of the crop was treated with Alar. New Jersey's not a big apple state, but we do grow several thousand acres of apples. After all of the settlement was done with Uniroyal and the U.S. EPA and things were taken off the market, and all those adjustments, she came and she goes, what percentage of the apple crop is treated with Alar? And I said, right now we're pretty sure it's about 0. So the farmers don't want to take the risk. And so she said to me, did you lie to me a couple years ago, or are you lying to me today? I said, I didn't lie to you either time. I told you the best information I had. One of the other things you have to learn about risk assessment and risk communication is to tell the truth. But sometimes when the truth changes, you can be left with a little bit of egg on your face trying to explain, the circumstances and how they changed. Here's an example of where the circumstances changed. This is an interesting story. Saccharin, or sweet and low. Saccharin, for those of you who are Hopkins graduates, of which there are many, outstanding school of public health, saccharin was actually synthesized at Johns Hopkins in 1878 and put on the shelf. No one really cared about it. And then in the 1960s and 70s, when Americans became dieters, by the looks of us, not terribly successful dieters, but we became dieters, saccharin became a sugar substitute. It was used a little bit after the First World War when there were some sugar shortages, but it didn't get a lot of play. But it got more play as a calorie-free sweetener in the 70s. And beverages like Tab, which was a Coke product that was a diet precursor of Diet Coke, was called Tab. They used saccharin, or sweet and low. And it was the most, this little pink packet was everywhere in restaurants and bars and grocery stores. It was the sugar substitute. And in the 1970s, people did some studies using rats. Remember our discussion earlier about who's a good surrogate. And rats linked with saccharin and bladder cancer. And Congress took a very interesting step in both public health history and certainly in risk assessment history. Congress mandated that future studies of saccharin had to be performed on all food that contained saccharin and bear the following label. All foods had to say, use of this product may be hazardous to your health. This product contains saccharin, which has been determined to cause cancer in laboratory animals. That was a very big step in the 1970s. You certainly wouldn't get away with it now even, but at the time it was a big step. And of course lots and lots of studies followed. And as these studies followed, they realized increased incidence of urinary bladder cancer at high doses of saccharin in male rats. And then they realized that it was a very straightforward thing. It only was in that one subgroup, and that it was unique to rats, and it would not apply when they did the mechanistic studies to humans. And when they did the epi studies, so cheers for the epidemiologists on the call today, when they did the epi studies, they realized that patterns of disease associated with urinary bladder cancer were not present associated with the saccharin use. And so in time, the label was removed, but it was a big step. So in the 1970s, they boldly put on the container that this causes cancer in laboratory animals, and something to think about. Now you may say, well, we have that for smoking too, and it didn't deter people from smoking. And you do see the Surgeon General's warning on cigarette packs all over the world. And smoking is still a pretty serious public health issue, but it's there, and we bring that up as an example. So let's talk a little bit about a couple of the big media in our lives: air and water and food. The earliest form of anthropogenic airborne emissions is wood smoke. And that's because humans needed something to burn, coal or wood, for heat and for cooking. And so this has been around for many thousands of years. It's not a particularly new problem. It's a historic public health issue. Coal smoke is probably contributed as a major part of air pollution all the way back to the days of the Industrial Revolution, so over 150 years. If you look at the little schematic, this is borrowed from US EPA. If you look at the little schematic, you can see that we have air pollution sources throughout our homes and in our workplace. Okay? In an industrial setting, we see ozone, particulates, and a number of other air pollutants that come from industrial sites. And then we get home and we get to see them all over again. When we park our car in the garage, we have carbon monoxide, carbon dioxide, volatile organics, and particulate matter, lead, and nitrous oxide. Microbial indoor air pollution is a serious problem. We've become more aware of that in the last decade or so. And it's circulated through our HVAC system and many other things. So we have considerable sources of air pollution both at home and outside. In fact, people will remind you that in indoor air pollution, sometimes, depending on the pollutant, the indoor pollutant concentration can be higher than it is outside. A good thing to remember. Great moments in air pollution history. Here in the United States, Donora, Pennsylvania, just a stone's throw from the University of Pittsburgh. Wonderful book written, by the way, from a faculty member at the University of Pittsburgh, Dr. Deborah Davis, called When the Smoke Flowed Like Water. Dr. Davis is from Donora, Pennsylvania, hence her writing this book. And this is a picture of Donora at 12 noon, and you can see it looks like midnight. Now, obviously, it's 1948. You can tell by the cars and the appearance of the buildings, but it was a remarkable event. A little industrial town south of Philadelphia. Is actually way out on the other side of Pennsylvania. Between October 26 and 31 in 1948, 20 people died and 7,000 people were hospitalized. And it happened as a result of temperature inversion. The cold air was trapped from all of these steel mills. Remember, Pittsburgh was a huge steel and milling and mining and refining city, and in the entire region, that part of Pennsylvania in the mountains, they mined coal and ore and everything else. And so all of a sudden, Donora and other smog problems led to this air pollution research that eventually led to the Clean Air Act that we know today. So they had this cold air diversion, and many, many people got sick and died. It was a sentinel event in environmental health history, and it was a very important contributor to the Clean Air Act that we have today. Now, I'm not trying to make a political statement in any way, but just to point out to you, especially those of you that are younger on the phone, on the webinar, that most of the great environmental legislation that we have had signed was signed under the presidency of Richard M. Nixon, who was a very interesting character on many levels. But the Clean Air Act, the Clean Water Act, revisions to the FIFRA Act that controls pesticides, many other regulations were all signed under the Reagan and then in the Nixon administration, and he often is not given credit for really being the pioneer as a president for environmental legislation. So here's another one of those inversion stories. This came 4 years later after Donora. This is the London smog of 1952. And it's an interesting one. Here are the deaths on any given day in London. So you see the deaths. This is days on the x-axis. The y-axis is number of deaths per day. And then on the other y prime, you see the measurement of smoke. At that time, we measured smoke in milligrams per cubic meter. Okay, that was a way to measure particulate matter, really. And as we look across the bottom, on an average day in London at that time in 1952, about 250 or so people would die. Over the period of this smog event, that number rose close to 1,000. And interestingly, it was not the doctors or the nurses or the hospitals or the public health officials that first noticed they had a problem. It was the undertakers, because the undertakers all of a sudden noticed business had literally gone up by a factor of 4. They needed coffins. They didn't have any. They just couldn't fit all these people into their schedule to manage the funerals. And so they were the people that really decided, holy mackerel, we have a big problem here. And you can see as well as that the number of deaths tracked very nicely to the concentration of the particulate matter or the smoke in the air. And if you look at Google Maps for the meteorological maps through Google Images for 5 December 1952, and I just think it's so spectacular that you can type in, as I did here, weather map, 5 December 1952, London, and this appears. it's just such incredible technology we have at our disposal now as public health scientists. And you can see what happened where they had the air inversion. And so keeping that in mind, we know that just like a jar that had a lid put on it, the smoke, the particles from the exhaust were all trapped there. It was cold, and when it was cold, people fired their stoves and made more heat, and had all of these activities just generate a lot more smog. When the air inversion took place, the smog did not escape up into the atmosphere, but instead stayed closer to the ground, like the jar that had the lid on it, and that lid kept it closer to people, and the people eventually, many of them were sick and died. So sort of a classic air pollution event. And what happened was it got unusually cold at that period of time, so lots and lots of people lit their chimneys, lit their stoves in their homes in London, and that caused a larger than normal pollution problem for people. All right, we ought to know about the sources and emissions that go into the air. And air pollutants are categorized for the purposes of regulation into two categories. So we should know this. We should know we have criteria air pollutants. They're called the CAPs. And these are things that really affect human health. That's what's so important about those. And they're CO and lead and NOx and SOx and particulate matter and ozone. And these are the pollutants for which EPA has established the National Ambient Air Quality Standards, the NAAQSs. Then we have toxic air contaminants. These are everything else that's up there but aren't CAPs. These are the TAC. And these are also referred to as HAPs. Now, as you know, one of the great challenges in public health is we have lots and lots of acronyms. But I think very much to the credit of the people that designed the exam is mindful of that and tries to keep it as straightforward and easy for you so you don't get bogged down in all the alphabet. We have the Clean Air Act primary standards are there to protect public health, to protect sensitive populations. Remember, that's always an important concept of public health. Sensitive, vulnerable, susceptible, all synonyms. Populations like people who are asthmatic, people who are elderly, and certainly children. And the secondary standards are to protect things like crops and agricultural enterprises and buildings. It's interesting, you know, if you've gone to Greece, the spectacular Acropolis in Greece, which is thousands of years old, has actually suffered more deterioration and more damage in the last 50 years than it did in the first couple thousand since it was built, mainly because of air pollution. So this is what those secondary standards will protect, you know, monuments and buildings and structures like that. So you may say, well, who's the biggest culprit in this story for air pollution? And the answer is, of course, motor vehicles. Motor vehicles account for about 1/4 of the emissions that produce ozone and about 1/3 of the ones that produce nitrogen oxide. Particulates and sulfur dioxide are also a big deal, and almost 80% of the carbon monoxide comes from transportation sources. So motor vehicles, big deal. What does it translate into? Healthcare costs. It translates into billions of dollars associated with 50,000 premature deaths and 40 or 50 billion dollars of health costs associated with air pollution. The American Lung Association, through lots of their work, said that probably 50,000 emergency room visits, with about 15,000 of them resulting in people being admitted. And we think about 64,000 or so Americans just here in the U.S. die from lung and heart disease that is related to the pollution caused by automobiles. As we've said many, many times, and so it's a good thing to remember, because if we keep saying it, you know, you're going to need to know it, not just for the test, but for your life as a public health person. Kids are more susceptible. We have double the susceptibility in pneumonia, bronchitis, and increased matter, decreased lung function and lung growth. Okay, we have increased asthma and asthma severity. We have lots and lots of issues associated with it. Certainly the adverse effects are correlated very highly with people who smoke in the house, which is a form of air pollution. common air pollutants are ozone, CO, NOx, SOx, lead, and PM, or particulate matter. We'll spend a minute on each of these. Good ozone versus bad ozone, important question. Reporters will ask you this a lot. You know, and sometimes they'll ask you to debate you, sometimes they genuinely want to know what the difference is. They call up Dr. Robson, I'm confused. One minute they're telling us to protect the ozone. The next minute they're telling us we have high ozone levels and it's bad. What does that mean? And you go, well, you're right or wrong on both. Okay. Good ozone is the ozone way up at the top that absorbs the UVB and protects us from excess amounts of damaging radiation. Bad ozone is what makes smog and is a function of volatile organics, NOx, heat, and sunlight all coming together to form ozone, and most of that is tailpipe emissions. And so, you know, it's the chemical reaction of pollutants, the volatile organics, and the NOx. It causes severe breathing problems, reduces lung function, irritates your eyes, may speed up the aging of your lung tissue. In homes without gas stoves, it can run 0.55 ppm, a little higher in homes that have gas stoves. If you don't adjust your gas stove, it's even higher. So that's the source. So here's a picture from New Jersey, my state, and this is days on which the 1 hour ozone standard was exceeded over about a 15-year period. And you can see in 1988 we exceeded it many times over the standard, 45. The data is pretty jumpy, but the point is that you're living in a highly urbanized state like New Jersey with the largest number of automobiles per capita, and you can see that, you know, the risk is pretty great. And every once in a while you think you get it knocked. Like in the 80s it was high, we got it lower in the 90s, but then it crept back up and it goes back up and down all the way through the data time that we see here of 2003. Carbon monoxide, you ought to know this one. Colorless, odorless, non-irritating gas generated by the incomplete combustion of carbon-containing fuels like oil, wood, coal. Interestingly, high levels of CO is a leading cause of death from poisoning in the United States, which is pretty amazing. The outdoor sources, as you can see, transportation is the lion's share, fire, fuel combustion, and some industrial processes. But in general, the largest cause of CO pollution is from the automobile. We talked about that before. Indoors, it can be poorly vented heaters, gas stoves, people that bring in, it's gotten very cold in the last few weeks here in the Northeast. People bring in all sorts of creative heating. It's very tragic to read about a person who, a few months ago when it got cold, brought in their charcoal barbecue grill and literally lit it up in the house and had it on in the living room for heat for his family, and of course the family was overcome by carbon monoxide. So even ETS, or environmental tobacco smoke, is a source of carbon monoxide. And you can see what the levels are. They range from 0.5 to 5 parts per million, and if you have the stove is not adjusted properly, it's going to be higher. It's kind of an interesting graph, so I put this in our talk. Carbon monoxide concentration rises with the early morning and late afternoon traffic. I think that, you know, so it tracks very nice with the traffic. Okay, and of course, you know, there's a lag time, as you can see. But if you look carefully, the CO concentration sort of drops, and then at about 5 or 6 o'clock when traffic picks up, it picks up, and then going home it starts to pick up again at about 4 o'clock, and then goes all the way up because of the change in the wind speed, because of the time of the daylight and the difference in the traffic. So it's kind of interesting to see how they're all interrelated. Here's a picture that talks about this warm air inversion. So under normal conditions, you know, the air is warm close to the ground. And as we go up, it gets cooler, finally to the third stage where it's quite cold. You know that if you've ever flown in a plane, they always give you the outside air temperature. It's minus quite a bit. Even if it's 95 when you take off, it's pretty cold when you move up. Atmospheric inversion. We have the warm air inversion. Of course, it acts just like a lid on a jar. And that lid on the jar, of course, is going to keep the pollutants and everything else that's emitted closer to the ground to affect first people, second livestock, and then finally, you know, crops and other things like buildings and monuments and so on. Nitrogen dioxide is a brownish, highly reactive gas. In almost every urban atmosphere, you have significant amounts of it, and it's again derived from fossil fuels that you burned. It also reacts to form these other products, including the nitrogen dioxide and other NOx products. Indoors and outdoors, the levels can be the same or even a little higher sometimes indoors. And a lot of it is from improperly vented stoves and kerosene heaters and things like that, as well as ETS. Outdoor nitrogen oxide is, along with the carbon monoxide, highest in the morning and afternoon rush hours. Of course, here in New Jersey, and I'm assuming for most of the people that are listening on our webinar today, that we used to have a pretty defined rush hour from like 7 until 9, and then again from 4 until 6. But now, traffic being so intense as it is, a rush hour is sort of a continuum. There are peaks of traffic, but the distinct times like we used to have are sort of gone now. Sulfur dioxide is mainly from stationary sources this time. It's not an automobile issue. It's from fuel combustion stationary sources like steel mills, refineries, and non-ferrous smelters and things like that. Highly irritating to eyes and nose and respiratory system. It can also aggravate your cardiovascular system and your respiratory system. It's the key, why we think it's important in environmental health. It's the key ingredient in acid rain, forming acid aerosols. And finally, it can cause the damage we mentioned about earlier, like the damage to the Acropolis, just deteriorating the quality of the limestone and the granite. Lead, I always tease and say that if you're stuck for an answer on a public health exam of any type, never leave it empty. Write the word money or write the word lead. They seem to appear more often than any other phrases we use in public health. Lead, of course, is a naturally occurring problem. It's also a problem that's anthropogenic as a result of our own activity. It's not quite the problem it was in the United States. Since we banned leaded gasoline, we banned lead paint, and we changed the way the smelters operate. In other parts of the world, it's still pretty significant. It's a neurotoxin, and it also can cause other problems like digestive problems and other health issues. Particulate matter, PM. PM, sometimes you'll see it as PM10, subscript PM2.5, that's the size of the particles. And the smaller the particle, of course, the more we're worried about it penetrating its way into the deep lung. And particulate matter comes from things like dust and dirt and soot and smoke and liquid droplets. Its sources are fuel and wood and diesel, as well as activities that are industrial, as well as agricultural activities. And it's stunning. I have projects in Southeast Asia, and the Indonesian rice farmers burn off the rice stubble, the rice straw, every year, and literally fill the sky for weeks with absolute, it's just thick. It looks like the pictures you saw from Denora or from London. It's amazing, except it affects the entire part of the continent and has enormous impacts on closing airports and causing health problems. It's just absolutely amazing. At the same time, they say, hey, we need to do this to plant our rice next year's crop, so we do. So far, no one's had the courage to make them stop. It's an irritant. It also causes haze, and it's hard for airplanes to land and take off, and it causes considerable property damage. I thought this was kind of interesting. This is lifted from an EPA document, a day in the life of one person's exposure to respirable particles, or particulate matter. On the y-axis, you have the pollutant concentration, and on the x-axis, you have the time of day on a 24-hour span here. And you can just see what the exposure is, and you can see that, interestingly, the respirable particle, some of the highest levels, are in one's home. One finishes jogging, as you can see in this mythical person, goes into their bedroom to change, and then it's home. 9 or 10 at night, the respirable particle concentration is quite high, and then finally they get up in the morning again. It goes down, and the day starts again. Indoor versus outdoor air pollution. Remember that 90% of people spend 90% of their time indoors. For sick young, meaning very young, like children, and very elderly people, that number is even higher. So even if you have a lower concentration inside than outside, you still have people at risk. It's pretty interesting that way. And just think about all the sources in your house of everything from new furniture to fireplaces to synthetic products like plywood or asbestos, disinfectants. They're all part of it. The last little thing before the break, of course, is a major source of air contaminant in a home includes environmental tobacco smoke if you have a smoker. It's amazing to me that 4,000 chemicals in the vapor phase or particle phase are contained in tobacco smoke. And remember, what we worry about with environmental tobacco smoke is not so much the smoker. He or she has their own risk, but all the non-smokers are exposed and have to deal with it. Asbestos is a known carcinogen, causes lung cancer, pioneering work done by Dr. Irving Selikoff at Mount Sinai in New York. And he also looked at the relationship, people always love this one, it's such a beautiful example, the relationship of smoking and asbestos use. And if you smoke, you have X risk. If you use asbestos, you have Y risk. And if you smoke and use asbestos, it's not additive like most risks are. It's in fact multiplicative. So the risk for lung cancer from smoking was 5. The risk for lung cancer from asbestos was 10. It's not 15 times greater for the person that smokes and uses asbestos. It is in fact 50 times greater. And it's one of those historical and very strong public health findings that have guided us. Here's what the fiber looks like. It traps itself in the lung. Interestingly, this advertisement from 1981, when the original World Trade Center was built, it's full of asbestos. They made the point that that was going to protect it. When the World Trade Center went down after the attacks on 9/11, many people argued had they not removed the asbestos that Selikoff was so insistent on, it may in fact be standing today. Here in the Northeast and parts of the other parts of the country, but particularly the Northeast, we have the breakdown of the radon daughters, the radionuclides, and radon, which is colorless, tasteless, odorless, will go ahead and emit from up through the basement into the living area in areas that are enclosed, and in fact increase the risks of several cancers, particularly lung cancer. People feel that there's probably over 6 million homes that have this risk, and we are also of the opinion that tobacco smoke and radon have a synergistic effect. Okay, it's 1:52. We'll reconvene at 2:02. Thanks. Okay, we're in the home stretch, and I'm proud of you that all but 3 people, I can see the statistics, we only have 3 people that left us. The rest of you have stayed strong and stayed in the group, and I'm very grateful to you for that. So let's look quickly at water, at food, and at kids. You need to know a little bit about water for the exam. Certainly water is essential for life, you know that. Water is represented very nicely through this picture in the hydrologic cycle. We talk about the activities of water as it circulates over and over and over again. Water is a pretty interesting resource in that regard. 71% of the Earth's surface is water, but almost none of it's available, less than 1%. And the majority of that 1% is fresh water and groundwater. So much of it is, of that 71% of the Earth's surface, that's water, is saline water that's not really available to us, as well as the water that's in the glaciers and the ice caps. Water is absolutely essential for us to live. We know that. Without it, we're going to die in a few days. We can live without food for quite a while, but water, it's a very short term. We're about 65% water by content. Blood is high, as you might guess. That's not a surprise, but I bet some of you didn't know that. Bones are even about 25% water. Water we always describe as a finite but renewable resource, but the rate of renewal is very, very slow. Our standard of living here requires about 100 liters per day for drinking, food preparation, dishwashing, and bathing. In fact, if you're an urban planner and you're planning sewer systems and utilities, you usually plan on a system that uses no less than 100 quarts per day. If you use less than that, the system doesn't function real well. The challenge, too, is that we have in an affluent society like ours, close to 200 to 400 quarts per person per day. As far as consumption, we're way higher in the United States than other places. WHO has reminded us that you can improve water access and reduce diarrheal disease by 25%. If you improved water access plus water quality, you didn't reduce it by as much as 37%. It's pretty remarkable. Of course, one of the great heroes in public health is Dr. John Snow. I guess Paracelsus was kind of a hero because he figured out that dose makes the poison, but John Snow was a bigger hero, of course, because he went out and did some real good shoe leather epidemiology and understood in 1954 in London about Asiatic cholera, even though he didn't know what the causative organism was. But he observed death rates around London, and in St. James Parish it was 200 per 10,000. And for that observation, he took the bold step, they tell us, removing the handle from the Broad Street pump. So here's Dr. Snow, in case you wonder what he looked like. He's an anesthesiologist by training, so he's a physician, but a surgeon and anesthesiologist who became sort of an amateur epidemiologist. And here's one of the proclamations that went out about the issues surrounding problems with people who had cholera in certain districts of the city. It's kind of pretty direct and pretty not necessarily very glamorous, but it helps you understand what the cause is, what the remedy is, and how to treat it. Here's the area in London, St. James Parish, where the Broad Street pump resides. You see the X's in the map are the different pumps, and clearly the cholera epidemic, the dots are the cases of the deaths, actually, not the cases, but the resultant deaths from the cholera, and you can see that the number of cases around the Broad Street pump was much higher than any other pumps in the city. And here's a picture of the Broad Street pump. We went to London, and of course I forced my family to all pay homage to this pump, something they never forgive me for. Taking that idea of Dr. Snow's pump and look at it today, you can see what we have as far as, this is taken from US EPA, what it looks like. You know, we have the confining layer of bedrock, we have the area, the water table, an unsaturated zone, and of course the area that we try to have on the top where the homes are built or the different kinds of industries reside. And that's sort of the scheme for what a typical water table looks like. Waterborne diseases have been a problem in the United States for many years. Classic events in the 1880s, typhoid killed about 100 out of every 100,000 people in the United States. And a severe outbreak took place in 1885 when 90,000 people were very ill in Chicago, and that was because the intake for the drinking water and the outflow for the sewage on Lake Michigan were very close to each other, and they had to divert that. Today we lose about 3 million young children from waterborne diarrheal diseases just because of lack of important sewage disposal and treatment. Fecal waste are just dumped out, and it just causes great risk. Now, historically, we had a problem in the United States where we had fecal waste that went into a cesspool. Some of you know what a cesspool is, and it's usually a little lined brick cistern, and the waste would sit there and it was stabilized by bacterial action. There wasn't really any disinfection used, and over time it would break down. At the advent of the flush toilet, when people were able to stay indoors and not use a privy outside, that changed the whole water pollution game and the whole public health game as far as sewage disposal. And from there we had to go in larger areas where we had to have public treatment works in rural communities and even suburban communities. People have an individual cesspool. We'll look at a picture in a moment, and a septic system. In the publicly owned treatment works for primary treatment, the sewage has all sorts of things in it: human feces, urine, laundry waste, things like that, as well as, my friends in water treatment remind me, sand, baseballs, rats, leaves, sticks, and everything else. And primary treatment, the goal is to get all of those suspended products, the waste products, out of the system, and then send it off to a place where there's a sediment tank where it can go ahead and the sediments will be removed through primary treatment. We try to reduce sediments by as much as we can, but typically 50 to 65%. And because of that, we're able to reduce the biochemical oxygen demand, the BOD, by about 25 to 40%. Remember, high BOD, organic matter consumes the organic matter there, consumes the oxygen. And if you're a fish and you're competing with the organic matter, of course the microbial activity on the organic matter will deprive you of the oxygen. When we move on to secondary treatment, that's more sophisticated. Depends on biological processes. We have a series of filters. We often use activated sludge, and we'll be able to reduce the amount of solids way down to almost 95% of the solids will be removed, and will greatly reduce the biochemical oxygen demand. Septic systems are a major way to treat household waste in rural and suburban areas. 30% of the people in the United States are on septic systems. Unfortunately, in the early days, salmonellosis, hepatitis, typhoid were all traced back to poorly managed septic systems in these areas. The septic system has two parts to it. It has a tank, and it also has a large field or sand filter. And the tank is buried in the ground, and in that tank, the sewage is partially decomposed. Solids flow to the bottom. The lighter solids and grease come to the top, and then they go out into the perforated pipes. They go out into the field. About every 3 to 5 years, you have to have this pumped. You have to take the solids out. So here is the anatomy and physiology of a septic system. Okay, so here's the home. Hopefully you're well. If you are on a septic, you're probably on a well as well, or also. The well should probably be as far away as you can possibly be from the septic system. So that you flush, it goes out to the septic tank, and then as solids drop out, it goes further over into the drain field, and then it works its way as a natural filter through the soil and through the soil layers back to the groundwater. Another picture of this time showing that you probably have the well as far away as you can from the septic field. We worry about this because there's about 200 plus chemical, biological, and radiological pollutants that are in groundwater, and we want to make sure that we don't further challenge this by introducing microbial contamination from our own septic system. These are primarily anthropogenic pollutants that occur from faulty waste practices, or poor land management. The primary drinking water contaminants are the chlorinated solvents, from industrial processes. Many of them are cancer-causing. The trihalomethanes are THMs. THMs are disinfection byproducts. And so DBPs from THMs, again, too many alphabets here. But these are when the organic matter in the water comes in contact with the chlorine. The chlorine is the primary treatment product, and the treatment option is chlorine because it's cheap and it's effective and it lasts a long time. THMs lead to cancer as well as liver and kidney disease. And of course, in older systems, we still struggle with the legacy of lead pipes and lead solder. And lead, as we said before, is a neurotoxin as well as can cause birth defects and cancer. PCBs, again, make their way into the water system from industrial processes, liver cancer, liver damage, bacteria and viruses from overflowing of the waste material, GI disease, meningitis. Just a little bit more about the THMs. It was in the 70s that we learned that the chlorine, which we know is a very important water treatment, to use chlorine to disinfect the water, would form in time these DBPs. In high doses, they can cause liver and kidney disorders, central nervous system problems, as well as cancer and birth defects. Lead has been a challenge for a long time in the United States. The legally permissible level of lead in water is 50 ppb. We estimate right now that about 40 million of our 300 million people living in the United States are drinking water that have over the 50 ppb level. Coliform bacteria, you'll see that a lot when you read water literature. Coliform bacteria by themselves are really not that dangerous. They are an indicator. Remember, in public health, we often use indicators to tell us the status of something. And so coliform bacteria, the presence of them in large numbers, tell us the water is not safe to drink. By themselves, they aren't a problem. It's usually because they are dispatched from the intestines of warm-blooded animals. A high coliform count means you have a problem. It does not necessarily mean that the coliform itself is going to make you sick. The other indicator we use is BOD, or biochemical oxygen demand. Okay? A low BOD is good water quality. High BOD means you have polluted conditions that I mentioned earlier when bacteria act on the organic sewage. Large amounts use the dissolved oxygen, which leads to fish kills and other destruction of the aquatic environment. The basic steps for water treatment include sedimentation, when we get the water to go ahead and quietly settle out. Coagulation, when we use hydrated aluminum sulfate to flocculate the precipitate and form these flocks that gets those solid pieces out. Filtration, either through beds of sand or diatomaceous earth. And then finally, disinfection. Chlorine is the number one. Smaller systems often will use ozone or UV light. The United States has been chlorinating water for well over 100 years, going all the way back to 1908 in Chicago. Chlorine is used in about 75% of the water supply today. Chlorine is one of those single important public health moments. Our students have a t-shirt, I guess most schools do, of great moments in public health, and one, of course, is the pasteurization of milk, the chlorination of water, the eradication of smallpox. The chlorine gets props. It gets to be up there with those other important events in public health history because of the number of lives saved through the avoidance of serious GI diseases. It's inexpensive, it works, and it lasts in the pipes for a long time. That's what makes it so important. When you travel other places, like this picture in Romania, with an open well like this, it gives new pause to the fact of what the water risk might be. An open well full of microbial contamination. Or this water source in Accra, outside of Accra in Ghana. In this picture, this is the village water supply. You can see people on the top part of the picture getting water to cook, and people doing laundry, and little kids that are swimming and playing and using it as a toilet and using it to bathe. This is the public water supply. This is why so many kids, 1 in 5, die of diarrheal disease. Oh, look at this picture. This is an interesting picture. This is public health practice picture now. This is a mayor and a village leader, and this is public housing. Again, this is in Ghana. And the mayor said to me, "Oh, look at our new well, Dr. Robson." And I said, "Do you think it might have been better to move it away from the open sewage area?" And she said, "You don't get it, do you?" She said, "You have to put the new well where the people are." I put it here because this is where the old well was, but I dug it deeper. It'll take a while for the microbial contamination to really impact it. So for right now, this is the right place for this well. You have to remember, you have to think like the people you're trying to help. And the mayor thought like her constituents. She knew that if she put a new well far away from where the people were, they would continue to use the old well and be at risk. So Public Health 101 means you have to think about what the needs are for the people you're trying to help. This is the physiology of a well. If you have a dug well in the back of your home, there's a screen at the bottom. This is a submersible pump, and then it pumps it up through the system into your home. And we call this whole little system here a casting. Okay, and you can see the casting is the outside pipe, and then on the top they usually have a sanitary cover. Just want to give you a quick little case study, some work that we did in the southern part of Thailand a few years back to talk about the importance of good, safe drinking water. This is a village. Each red dot represents a home that has a arsenic level up above 200 ppb, up to 1,000 ppb in some cases. The yellow dot is between 0 and 200 ppb, and the blue dot is a home that has no well, but it's a home. So their water source is one of their neighbors. And in this is in southern Thailand, where it's a real serious problem, naturally occurring arsenic in shallow wells. The safe level for arsenic, according to the World Health Organization, is 5 ppb. Here in the United States, we think it should be at least, WHO is 10 ppb. Here in the United States, we think it's 5 ppb. Here there are people with up to 1,000 parts per billion. And what that means, first pass, it's Mullen's disease, followed by palmar-planar keratotic lesions, as we saw in the people in the villages, followed by full-blown skin cancer. And 30% of the people in some of these villages had a level like this, which resulted, of course, in this person's death. So it's pretty remarkable. How do you resolve the problem? You resolve it with deeper wells. We go past the water table where the arsenic is resident. This beautiful little boy is taking a bath, his words. It's very cold water, I can attest to that, but it's a couple 100-foot deep well, and so it's arsenic free. And you know, when you think about it, water is one of those things that's essential. We talked about at the beginning of the talk, and yet if you don't have clean access to water, you can't afford a deep well, you're in a whole lot of trouble. We're going to take a minute and talk about food. Food is important because, of course, it's what sustains us. Here's a rice paddy up in the north of Thailand. Notice the intimate relationship between the environment, the water, the soil, the rice. It's all interconnected. Environmental health is important because it's not just one discipline. It's practically every discipline. And food comes in all shapes and sizes. You know, we eat a variety of food. At times our food can in fact be a detriment to us. We're trying very hard now to get a better handle all over the world on what we eat. This is a study we did on Thailand because we had some contaminants in fish. But you know, just like here in the United States, we're not always sure how much we eat. If you asked me before I started this diet what my calorie consumption was, I'd say, oh, it's around 2,000 calories. Once I started to count it, I realized the reason I was too heavy was it was many times more than 2,000 calories. And you know, you have to learn what, not only what you eat, but how much of it that you eat. And that tells us a lot. Food often requires pesticides to produce it. In Thailand and around the world, we look at how much pesticide people introduce into the food system. Here in the United States, of course, the most famous story was Rachel Carson in the 1960s when her book came out in 1962 about the endocrine disruptor DDT that was killing birds. It was killing birds, but also longer term caused health risks with us. We now know better. We try to test things for their long-term environmental hazard as well as their human health hazard. We also try to protect people by what they use when they apply the pesticides. This is a questionnaire that we gave to Thai farmers, but you might as well give it to U.S. farmers too. What is your protective clothing you use? Number one choice was none, which by the way was also the number one answer. It would be the number one answer in the U.S. But it's interesting, look at some of the other answers or choices. This is the translated questionnaire back into English so I can show it to you. Knitting faces hat and loincloth. two things that were a little hard for me to get my arms around until I actually went out and met some of the people participating in our study. Here's the Knitting Faces hat. This gentleman is wearing a ski mask. Oops, a ski mask, and he's trying very hard to protect himself. And in food production, of course, they've increased pesticide use by about 300% in Thailand. They're producing more rice than they ever did, but they haven't given people good instructions on how to properly use these compounds. And so that's a big problem for folks. And you can see what it looks like. So he thinks he's protected. Cotton mask, cotton shirt, cotton shorts, short sleeve shirt, and off he goes. Another interesting one in the production of food globally, of course, is this gentleman. This guy is applying a potent organophosphate, azofosmethyl, to oranges up in the north of Thailand. That mask appeared on that gentleman about the time that your instructor appeared. It's amazing how that happens. And he's spraying a pretty potent compound, and so I gently said to the farmer, don't you think you should have better protective clothing for him? To which the farmer replied, which stunned me, oh no, he's Burmese, there are plenty of them. So his approach to occupational health was to have an adequate workforce to replace the people that may fall ill and become sick. So when we do environmental occupational health, we always struggle with, the worker safety and how the employer, in this case, values or doesn't value the worker. Okay, we're in the home stretch. And we're going to talk a little bit now about kids. And then we'll, the only question that popped up so far is, Aaron, is the question about the sound went away, but of course we got that back. That was earlier. So if there are,
I think that was when we were on break.
Okay, so if there's a question, we'll try very hard to. If some questions come in, we'll try real hard to answer them. So let's talk about kids as we come into the home stretch of our webinar today. And when I obviously pirated this picture, and I always wondered, having been a parent myself, how you could possibly get them all to stay in there. Either Photoshop or maybe they just glued their little diapers into the bottom of the pots. But anyway, here we go. When we look at environmental health, we have a couple of truisms, as we like to say. It's a truism in toxicology that humans are not simply big rats, and attempts to make risk assessment and do it effectively and look at the differences between humans and rats. You really have to just realize that it's a very different, much more complicated system. And the final one that's even harder to comprehend is that kids are not just small adults. So people aren't big rats and kids aren't small adults, and you have to keep that in mind as we go forward. Kids take in much different units of per body weight of air, water, and food, and the contaminants that are associated with them. They have different pharmacokinetic behaviors from that ADME that we talked about earlier, the absorption, distribution, metabolism, and excretion of chemicals. It's quite different. Because they're growing and developing, we can't compare them directly to adults because their metabolism is different. And I think it's so amazing that in a period of 26 weeks you can have, two little cells, a sperm and an egg, the conceptus, and that can grow to something that actually looks like a person weighing about 500 grams, or about 1 pound, in the 26 weeks. Now, as we know, the last part of pregnancy, it's really a little hotel for someone, and the kids just, they physically grow. But that first 26 weeks is active development, and it gets all the way up to about 1 pound. And after that, you can recognize the different body and organ systems, cardiovascular, GI, immunological, etc. And they're sufficiently mature. It would be very hard for the babies to live outside of the uterine environment, but they can. Hopefully they'll have time to remain for the rest of the gestation, that next 12 weeks, so that they can grow inside. So now you've taken that 2 cells, and 38 weeks later you have something that's 3.5 kilograms. To me, that's just a remarkable event. And from birth through adolescence, physical growth, functional maturity of the body continue until you have decline in old age. And there are different susceptibilities to different environmental chemicals as we go through this time span from neonate till geriatric patient. Okay, and changes in body weight, changes in body fat and body water, and the whole composition of our body changes dramatically through this period of development and then gradual maturation and decline. Now, we said earlier, that in general kids absorb chemicals much faster, and so they actually are at greater risk because they have enhanced toxicity. The neonate the ability to eliminate drugs via the kidney, which is a major excretion pathway, is very limited because the kidney is not that well developed. Your kidney is a really important organ to protect you, and when you're very new and very young, your kidney hasn't developed enough. We have increased respiratory volume and ventilation in infants and children as a result of greater inspired air. So particulate matter, if you and I are standing there and we have a 2-year-old standing next to us, the concentration of the pollutant is the same, but the exposure is much higher in the child just because of the respiratory volume. Newborn has about 10 million alveoli, and by the time that they're 8, they have over 300 million, so that's pretty exciting. Their alveolar surface goes from 3 square meters up to 75 by the time they're an adult. So again, what they breathe in is a big deal because there's a lot less ways for them to protect themselves. Here's a little cartoon from the EPA that reminds us that children eat more, and they drink more, and they breathe more, and they play, and they're in direct contact with contaminants just by the very nature of their activity. And over the years, we've seen various articles that have highlighted this, as this older copy of U.S. News and World Report that talked about kids at risk and environmental poisons and disabilities. This is one I borrowed from Dr. Howie Frumpkin years ago when he was still at the CDC. And he used it in a talk, and it says, that the typical environmental exposures back in the Renaissance time, so several hundred years back, were infectious agents, fire byproducts, things from combustion like particulates and PAHs, and heavy metals like mercury and lead. If you fast forward to 2015, you have all of those things, plus you have the new risks that are new exposures that children have: pesticides, vehicular emissions, chlorinated byproducts, and industrial chemicals. They are all still with us. And the new ones add to it, and together they make exposures and the risks much higher in these children. Now, we've had success stories in the United States. I think this is one of those classic environmental health stories that really the United States government can be proud of. The people that work at the CDC can take enormous pride in this. And so, prior to 1976, we had lead in gasoline. In 1976, unleaded gasoline was introduced. The blood lead levels, as you can see, were about 12, almost 13 micrograms per deciliter at the time. The unleaded gas came out in 76. Lead paint was banned in 78. We got rid of solder, and of course, this is a CDC slide, so they also point out they had the first CDC grants that had just ended the series of grants to talk about lead reduction. And if you fast forward about 8 years, you see a wonderful dramatic decrease in the blood lead levels of people in the United States. And they go down to about 2.7, so it's pretty dramatic, and we continue to see it drop. And you see some sentinel events, lead gas completely gone in 96. HUD has grants that they introduced in 93 to reduce lead in homes. Copper and lead rule went into effect in 91. All of these things had a measurable and real impact on environmental health, and in this case, the biomarker was blood lead. So this has been our adventure today. I tried to keep it to 2.5 hours. I have a couple, I think I can read them. I have a couple the questions. I just have to learn how to scroll here. I can draw and drag that out now. Here we go. Can you discuss BOD more causes, outcomes of high level? Oh, sure. Okay. That's a good question. Thank you. So why is this a big deal in the United States? Well, so biochemical oxygen demand is when you have pollution that makes its way. Well, biochemical oxygen demand is the metric. Okay. It becomes a problem when we have too much organic matter like fertilizers or waste or things that go into streams and pollute it. And when it does that, when we have eutrophication, for instance, when we have, for instance, in agricultural areas where we have animal waste that makes its way into streams. This is a freshwater phenomenon. It's not a coastal saltwater phenomenon. It's a freshwater phenomenon. So you have the organic matter, you have nitrogen from crop farming and animal waste, you have things like that that get into the water, you have algal bloom, and when you have algal bloom, as an example, when you have too much potassium or too much phosphorus, these algal plants will go ahead and they need oxygen to survive. They will use up the oxygen, if you will, and that will adversely affect the other life, mainly the fish and other animals that live in the water. And so they will have oxygen deprivation, and so they'll die. So you'll have fish kills, large fish kills, and then you won't have any fish to inhabit the water body. From there, you won't have fish that are available for people, especially people that are sustainable fishermen, to go ahead and have those fish available as a food source. So where is it a problem? It's a problem around the country, and it's a problem in areas where we still have lots of animal agriculture. Now, I grew up on a farm before somebody sends a nasty email. I grew up on a farm. We had dairy cows and everything. But you have to have a well-managed agricultural enterprise where you're able to go ahead and not allow the animal waste to make its way into the waterways to pollute it. We increase the organic matter, hence you have the bacteria and other organisms are competing with the fish for the oxygen. So that's a long, rambling answer to a very thoughtful question that someone asked. And basically what we want to do is try to keep the waterways clear, manage the organic waste that makes its way into water supplies so that we keep the BOD low, and we go ahead and have higher water quality. Any other questions? Oh,
Looks like we have one more question.
Okay.
How do we manage, do you see that one?
No.
Okay, it says
how. Just read it to us.
It says, how do we manage the risk-benefit of chlorinating water?
Oh, that's a wonderful question. That's a very thoughtful question. So here's the trade-off, okay? We know that if we don't chlorinate water, the risk of microbial contamination and resultant all sorts of diseases, everything from straightforward ones like diarrhea to more complicated ones, become a huge risk. In fact, in Peru, a few years ago, they decided to stop chlorinating the water because they thought the risk was too high when they learned about the THMs. And then they had thousands and thousands of people die of diarrheal disease. So how do we manage it? We manage it three ways. Certainly we know enough now about chlorinated water that we don't have to over-chlorinate. We know the right amount we can put in the water. If we keep the organic matter out, we can reduce the THMs, which are in fact the real risk associated with it. The risk-benefit of chlorinated water is always going to be on the side of chlorinated water is a big benefit. I mean, that's pretty clear. And I think while people can argue, well, you can ozonate it, you can use UV light, that's all swell, but that can't handle large municipal systems. That's like now people worried about chlorine exposure and THM even in swimming pools. We did a study here, Dr. Cliff Wiesel, and I was one of his collaborators, but he was the PI, looked at master swimmers and their exposure to chlorine, in pools, because again, we'd sort of be the ultimate exposed population for chlorine in swimming pools. And at the end of the day, the risk is still pretty clear that a non-treated water body for recreation, or certainly non-treated water for drinking, is a big enough risk. So the way to manage is keep out the organic matter so that you avoid the THM formation, the trihalomethane formation. It's still, at the end of the day, nothing is without risk, but I think the risk is still, considerably on our side to avoid microbial contamination. It's work, and it's worked for over 100 years, and we haven't come up with too many good alternatives. Remember that 1 in 5 children die in developing countries from microbial diseases, diarrheal diseases, because the water isn't chlorinated, and that's a pretty remarkable number. When we teach risk assessment, we talk about 1 in a million risk. And a few years ago, I gave a talk on 1 in a million risk in Accra, in Ghana. And as I finished the talk, it was clear that there was a young physician in the back who was either very uncomfortable in her seat because of the chair or very uncomfortable with me as the speaker. Unfortunately, it was the latter. And she jumped up at the end of the talk and said, "Thank you for your presentation, Dr. Robson. I am a physician in Kumase, not far from Accra, and where I practice, 1 in 5 children will die of diarrheal disease before they're 8. And 1 in 5 children will die of malaria before they're 8. That's 2 in 5, Dr. Robson, or 4 in 10, or 400,000 in a million. Your number of 1 in a million is so irrelevant, so impertinent, so ridiculous. I don't know why you came to give this talk." And sat back down. So I had to politely say, "Well, thank you for your thoughtful remarks. I agree with you, doctor. You're absolutely right." But this was the topic I was asked to give. By the way, I raised the same issue with the organizers, who were pretty hard on me, saying, "Well, why don't you think that in a developing country we deserve the same risk standard as the developed world?" So I went and gave my talk on 1 in a million risk, and got that kind of response. So, you know, at the end of the day, something like chlorine is still an effective, appropriate way, and lots of people would like to have the infrastructure to use it. What we have to do better here in the U.S. is to keep out the organic matter, not to let the disinfection byproducts form, and certainly to do a better job as far as keeping the amount at the lowest possible amount and still be efficacious. Well, that looks like it. I'm grateful to all of you for your kindness and sticking with us. I wish you the very best of luck on the test. And you can shoot me an email at Robson, R-O-B-S-O-N, at Rutgers, R-U-T-G-E-R-S.edu, and tell me sometime if you thought this was useful. I would greatly appreciate some thoughtful feedback. Okay, be well, be safe, and thanks a bunch.
Wonderful. Thank you so much, Dr. Robson, for sharing your expertise with us today. And as a reminder, this presentation will be archived on the NBPHE website, as well as the other 3 categories. And you may register for the remaining 2 sessions, the Behavioral and Social Sciences, and Biostatistics, on the National Board of Public Health Examiners website. Thank you very much for joining us today, and this concludes our session. Have a good one.